Good afternoon, everyone. Give us just a moment here as we're letting other attendees into the meeting today. We'll get started here in just a moment. While you are waiting, I do have a poll question I wanted to go ahead and input here so that you could start giving us some feedback. Today's question is just asking for your unique responses and answers. Just one word to describe your menopause journey thus far. I know this will be pretty wide range, and we'd love to just get some feedback from you here while we're waiting. We'll get started here in about 2 to 3 minutes as we are just letting others into the meeting today. As we start seeing some responses, definitely use the chat. That's your safe space. You can definitely, put in your responses as well as, any questions that you might have. We'll get started here with some introductions as well as some webinar need to knows. Again, for those just joining, we do have a poll question, just asking for your responses in regards to well, how is your menopause journey thus far? If you could use one word to describe it. We'll go here in just another minute. I'm seeing a lot of responses and answers. Thank you so much for taking the time to give us your answers. We'll do introductions here in just a moment, Dr. Lisa, so everyone can know exactly who you are. But I'm sure some of these answers you're seeing are ones that are probably consistent, ones that you've seen before in your practice.
They are indeed. I put the one that says medically supported.
I love that.
But I may be an outlier on that.
Yeah, this is fantastic. Thank you all so much. We really do value, and we ask these questions. I know we do these webinars monthly. For those that have attended in the past, we do ask these questions, and we do use some of the information that's gathered just for us to formulate, how we're, how our attendees are feeling. And so we really do appreciate you just taking some time just to fill that out. And for those that this is your first webinar that you're attending with Jeanette, we certainly do appreciate it. For those new, we are going to get started officially here in just a moment, just waiting for some others to enter the meeting itself. We'll get started about 4 or 5 after the hour. Perfect. Alrighty. I don't see anyone waiting, so we will go ahead and get started today. Thank you so much for joining the month of July's webinar series that we are doing here at Genève. Today's webinar, as you can see here, is just about Menopause 101 and giving some details kind of around that, and hopefully kicking off some conversation between Dr. Lisa and yourselves. The chat room and also our Q&A section is open and available for any of you that might have some questions that maybe feel prompted as some of our discussion is taking place today. And so wanted to give you that detail, but wanted to go ahead and just let you know, starting with introductions, if you will. If you, again, have attended our webinar in the past, my face is familiar, but Dr. Lisa's might be new as a face to you today. But for those that have not attended one of our webinars in the past, my name is Tyler Rouse. I am the Senior Account Manager of Partnerships here at Genève, and I am joined here, like I said, by Dr. Lisa Savage. She is a board-certified obstetrician and gynecologist and has spent 3 decades taking care of women. She received her medical degree from Baylor College of Medicine and did her residency training at Emory University. She was in a private practice in Austin, Texas for 25 years before taking a sabbatical, and during which time she started working with Genève. She is a fellow of the American Congress of OBGYN and certified by the American Board of OBGYN. And then outside of medicine, Dr. Savage enjoys time with family, hiking, travel, and volunteering with canine rescues. A few webinar need to knows. Feel free, like I said, to leave any questions in the chat, and we'll gather those for answering at the conclusion of today's webinar. And as a reminder, I'll do my best to also keep an eye on this, but please stay muted during the duration of the talk. It just helps the flow in the recording be cohesive from beginning to end. And from there, what we'll go ahead to do and just move straight into kind of the agenda of today's topics, what Dr. Savage is going to be talking on today, is what is menopause and the entire story around that, and moving from there directly into symptoms. And then more uniquely, how does Genev treat those particular symptoms that someone might be presenting as a patient of ours? And then a kind of the MD model of care and then next steps. And then at the conclusion, like I had mentioned, we will leave room for questions and potentially any answers that we can provide. And not without further ado, I've been talking up quite a bit, but Dr. Savage, I'll let you take it away.
Thank you, Tyler. Welcome, everybody. I'm really excited to be here. I was so intrigued by all the words that were used to describe the menopause journey, and we're definitely going to talk about some of those as we go along. But let's just talk about this slide first, understanding the transition. Somebody put a word in there that said dynamic, and that is really a key word in terms of the menopause transition. It is dynamic, it changes over time. Menopause itself is defined as a year without a period. That's a milestone. You've been a year, no menstruation. But leading up to that is this transitional time, and that transition may take a few months to a few years, usually starting between age 45 and 55. And this says about 7 years, but can be as long as 14 years. Some patients start in their late 30s to have some changes. The 40s are definitely a decade of change, and on into the early 50s when the average age of menopause is about 51, 52. By the age of 55, 95% of women are through the transition. I like the last paragraph that it says affects each woman uniquely and in various ways. One woman over the course of time will be affected in various ways. Just as soon as symptoms start, they might stop and then they come back again. So dynamic is really a word that we use when we talk about the transition. Next slide. All right, so here we have this divided into these distinct stages, which is good and instructional, but I want to point out that it's all a continuum, it's a spectrum. It's not that perimenopause has a box around it and you can only have these symptoms, and then menopause has only these. No, 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 everything is a continuum. Perimenopause refers to this transitional time, the time during which changes are happening. You're not a year without a period, but man, the periods can get extremely variable. The cycles may be shorter or longer. The flow might be lighter or heavier. It's unpredictable. And perimenopause is characterized by what I call ovarian chaos. Ovarian chaos means that we're not having the nice, neat cycling and ovulations and hormonal levels that we had in our younger reproductive years. So, if you will, perimenopause is ovarian chaos. Some of the leading symptoms are those listed. Mood symptoms come out on top. This phase may not have a lot of the hot flashes and night sweats that we speak of, but mood symptoms are prevalent. Other symptoms as well, starting to notice change in body composition, sleep disruption, which I talk a lot about in terms of being a cornerstone of other symptoms. Menopause itself, a year without a period, all of the aforementioned symptoms may be ongoing. And then we have the addition over time of sexual dysfunction because of tissue quality. The vulva and vagina may become thin, dry, fragile, uncomfortable, less arousable. And so a lot of times those genital changes will show up in menopause and then beyond. Again, the average age is 51, but anything from 45 to 55 is absolutely normal. There is a wide range. Postmenopause is ever after. It is everything from a year without a period until the end of your life. This is the stage of life and the menopause transition where we start to really be concerned about long-term health effects, lipids like cholesterol, cardiovascular risk, bone loss, and of course, social issues as well. And so we like to embrace all of these stages and emphasize the continuum, but it's nice to look at these individually as well. All right, menopause symptoms. These symptoms are just as varied as the words that people use to describe their menopause experience. And as I mentioned before, you may have some of these, you may have all of these, but at different times. You may have some that resolve and others that appear. And so this diagram or list of symptoms, there are a lot of them, if you'll notice, and some of them might be unexpected. Brain fog, for example, cognitive changes, um, joint pain and body pain can be very prevalent. And in fact, I'm not even sure I see joint pain on here. But that's one thing that we don't necessarily associate with menopause, but we see it a lot. So if you have had any or all of these symptoms, you are in good company because a lot of women rather in this transition will have some of these as they pass through. All right, so here we go about getting care for these symptoms. This slide says that less than 1 in 5 women seek care, but if I were writing this, I would say less than 1 in 5 get care. So I believe that probably more women than 1 in 5 do seek care, but this is the very disappointing reality. There aren't a lot of physicians who are trained in menopause management. And even my own colleagues in OBGYN, I am sad to say, sometimes don't get training in menopause management. So women go to physicians, but they're dismissed sometimes, or the physician just doesn't seem to know much about it and doesn't really want to engage with it. There was a big study back in 2001 called the Women's Health Initiative that really dampened women's ability to get valid information about menopause and hormone therapy. And that time frame also coincides with a lack of training and residency programs. And so at Genève, we're trying to sort of answer that void by having a whole cohort of physicians who specialize in menopause care. It's really a niche. It shouldn't be. It should be something that a lot more doctors are very comfortable with. But insofar as they're not, we feel that we have a real mission here to get the word out about menopause, to change the conversation, and to offer some real solutions. All right, so here's an example of what working with a Genève physician might look like for an individual, and of course, everybody's different. But at Genève, we really strive to integrate our care and look at the whole woman. So we have our physician appointments, but in addition to that, we integrate our care with a wonderful team of RDNs or registered dietitian nutritionists. They're all experts at midlife nutrition, metabolism, weight management. So many of our patients are struggling with weight and changes in body composition. And so the MD team and the RDN team are really committed to working together on a patient's behalf. And if one of our physicians sees that a patient would benefit from working with one of our RDNs, we make that connection. And we also collaborate outside of visits. We freely communicate with one another about our mutual patients, and it's very satisfying for the patient and her care, as well as our medical and nutritional team. We also pay really close attention to the emotional, psychosocial, mental aspects of this transition. It's huge. And and a lot of times in perimenopause, as I mentioned, the mood symptoms are pervasive. And so we also have at our disposal different resources for supporting women in their mental health. We've got individual clinicians, we've got different practices that we can help a patient connect with. We support all resources as far as supporting that mental health part of a woman's transition. At our medical appointments, for example, we do depression screening for every single new patient and every annual patient. So we really have our finger on the pulse of that piece of the menopause transition. Depending on the patient's presenting symptoms, her treatment plan, and what other support she needs, she may have as many, say, as about 7 appointments with various clinicians over a year. Sometimes not. I'll see patients who are very straightforward. They don't necessarily need support around other areas. I will see her for a follow-up after our initial visit, and then she might just come back once a year. But that's highly individualized. And it just depends on the circumstances as to how much support a patient will need. All right, here's another slide illustrating how we integrate our care. Um, we we really focus on not only collaboration, but within our medical ranks, we are committed to evidence-based care. And that means that we use guidelines from the American Congress of OBGYN or the Menopause Society. Our work and our recommendations are backed up with solid scientific data. So our team of medical doctors is all of one mind in terms of the standard of care which we follow. As I mentioned, we have the nutritional support as well, and we try to look at not only the whole woman but the whole transition because the needs will change over time. Again, it is dynamic. All right, next steps are here. Tyler may have a few more words about that. But in general, if a patient is interested in seeing a Geneve physician, our website at geneve.com is a very easy way to do that. You can self-appoint. We have a lot of resources on our website. We have articles and blogs and podcasts and all manner of free information because education is key. Women feel empowered if they can learn more about menopause, if they feel that they are not alone during this journey. And we are truly committed at Geneve in forming a community around menopause and around our patients.
Wonderful. Thank you, Dr. Savage. I, really appreciate just the conversation starters. I think that oftentimes this presentation can help spark just even amongst friends, amongst people in the same, just the same symptom groups, if you will. For us, as far as next steps, Dr. Lisa laid it out very perfectly. We'd love for you to be able to create an account at Geneve. You can do that by going to geneve.com. We have just a get started button, if you will, just on our main homepage. By creating that account, from there you can input your specific insurance information where applicable. We have a menopause assessment that we'd love for you to fill out. That's kind of the precursor, if you will, to meeting with one of our clinicians, one of our OBGYNs. It's a way for us to basically establish when someone is walking through the virtual door, if you will. It's arming our OBGYNs with information to best serve you and take care of you. And, one way that I like putting it is I feel like for Geneve, the services that we provide, we firmly believe that it's services that you need. I think Dr. Lisa would definitely say that as well. It's services that you're needing because we're there to help. But I always like saying and adding the extra verbiage that it's care in what you deserve, and you deserve to find out more about the symptom that you're experiencing, and having people in your corner understand what you're going through, I think can be pretty powerful. So this kind of moves us into the questions portion of our presentation, which is always my favorite when we do our 101 sessions, because our questions are very wide ranging, and they're very unique and specific. And so I usually do give the disclaimer, our webinars, we'll do our best to answer your question to the way that we're able to. We can't give specific medical advice in this particular scenario or session. That's where setting up an account and having that one-on-one experience with one of our doctors would be the best place for that. But Dr. Lisa, we did get a question I wanted to ask you to kind of kick us off here was, can some of the symptoms from different stages of menopause overlap, excuse me. For instance, can you be in menopause and have symptoms of postmenopause?
Absolutely. It's a continuum. It's absolutely a continuum. And some symptoms that start during perimenopause might fade away, others might not. Hot flashes tend to be real persistent. They'll start in perimenopause, and I'll see women in their 70s who are still really reporting, if not suffering, from hot flashes. They may come and they may go, but there's absolutely overall. It's all overlapping over time. Yes.
Perfect. Thank you. One other question someone had was in regards to treatment specifically, but does treatment include testing for insulin resistance?
Not necessarily if we're just managing menopause symptoms. Now, that brings me to a separate topic, which is that Genève has a weight management program. Some of our OBGYN doctors are actually double boarded in obesity medicine. And so that program is very specific. And that particular test might have more of a role in that program. We are not primary care physicians, we are consultants. If a patient were to see, however, one of our RDN staff and that lab was deemed to be useful or indicated, they would check with the physician. We do have a mechanism for that. And so everything is individualized. Labs are not a big part of what we need to manage menopause, but it's true that some of the metabolic changes might benefit from some look at that, and that would usually come with that collaboration between the RDN and the medical.
Absolutely. Yeah, I think that collaboration is really important, at least from my, Genev's point of view is, the services that our OBGYNs are providing in conjunction with the services that our RDNs are providing. It's a really powerful partnership internally that I think I would love to see more of our patients utilize because you're getting this well-rounded approach, if you will.
Well, and you know what? It's true that in medical training, doctors don't get a lot of education or training in nutrition. We don't. And I always say, we can all say the word Mediterranean diet, but we really don't have the in-depth training and background and experience, which is why we have this integrated plan. Because I am very good at the medical clinical part, but not having had a real background in nutrition. I love it when we can loop in our RDN staff and support the patient from both aspects because most women, honestly, they need both. And so we can offer both things.
Yeah, that's wonderful. Someone additionally had asked, having a partial hysterectomy, is there a way to tell what phase you're in?
So that is a very good question. So partial hysterectomy, let me just clarify the terminology. So that's actually not a medical term. When we say hysterectomy, it's usually a total hysterectomy, like the entire uterus comes out. But what people mean when they say partial is that they kept their ovaries. So I'm assuming we're talking about a complete hysterectomy with ovarian conservation. In other words, you've kept your ovaries, but you're not menstruating anymore because your uterus is gone. So there are some ways to tell. I mean, most women will have symptoms. You don't have to stop having periods to know that you're in florid menopause. And when you're 50 years old and you're having 15 hot flashes every day, some women sail through it without a lot of those symptoms, and we call the hot flashes and night sweats vasomotor symptoms. Um, Most of the time, women, even if not menstruating, will absolutely have symptoms. So it becomes less clear. We don't have that 1 year anniversary necessarily, but it's not critical in some patients to know exactly that it's been a year. When was your last period? Symptoms are going to be more what we rely on in terms of how we are going to treat or what we're going to be able to offer for treatment.
Understood. Thank you. There was another question that someone had inputted. It was a little bit further down, but I feel like it might be applicable based off the previous question. But it was, how do you know where you are in the process if you have an IUD and cycle stopped years ago?
That is a very good point because a lot of our patients do have the IUD, the Mirena, a progestin secreting IUD. And one of the beautiful things about that particular IUD is that it can control irregular bleeding, it can control heavy bleeding. It's a great contraceptive device. But that's true. What if you're saying you're not menstruating, just like a hysterectomy patient is not menstruating, so we don't have the menstrual history to go by? We generally go by symptoms. If you're age appropriate, say you're 48 and you have a Mirena IUD, you haven't menstruated in a long time because of the Mirena, but you're having classic symptoms, hot flashes, night sweats, sleep disruption, moods, we can confidently make a diagnosis of perimenopause, if not menopause. The distinction, if you're not menstruating for whatever reason, is not super important. The symptoms are what is important. We're going to base our treatment on symptoms and we titrate therapy to symptom relief. So the lack of a menstrual history doesn't slow us down a bit. In fact, I love it when there's no menstrual history for whatever reason, hysterectomy, Mirena IUD, because it becomes easier. Irregular bleeding can be part of adjusting to hormone therapy for women who are using it. So it's kind of liberating if we don't have to worry about the bleeding facet of it. But rest assured, we don't have to have that exact menstrual history to make good decisions about what to do.
Understood. Thank you. Someone had also asked, kind of through the similar vein, if you will, does not having a child in your lifetime affect the menopause process?
It does not. So whether or not you've had childbearing does not affect either the age at which you'll go through menopause or how you're going to experience it. It doesn't. One thing that might predict the age at which you might go through menopause is your family history. Ask your mom if you can. Older sisters, older female cousins, family history may be somewhat telling in terms of what to expect. But childbearing does not have an impact on the age at which you'll go through it or how you're going to experience it. Very good question.
Fantastic. Thank you. I was answering a quick question about insurances, and so I provided the answer in regards to who we are in network with. We're in network with Aetna, United Healthcare. Our new insurance that we just added was Anthem Elevance, and then we're in network with Progeny Menopause as well. I am your go-to person here at Gennev for any additional questions around that. So I'd be happy to help answer any of those specific related ones. But kind of going back to questions that I know Dr. Lisa is way more qualified to help answer and provide context for. Someone had asked Dr. Lisa, how common is it to have all three stage symptoms? How common is it to all three stage symptoms when in postmenopause? How common is it to see maybe symptoms that are associated with all three in
Right.
postmenopause?
Well, the good news is that over time, symptoms do get better on their own. So, for example, the hot flashes and night sweats that might be really wicked during the actual sort of perimenopause into menopause, they get better. They get better over time. Most of these things are going to get better over time, but a long time. I think sometimes if women knew that this was for 2 years and then it was all done, they could handle that. But the fact is, they're always trailing symptoms. But the good news is most of them will get better over time. We like to treat while they're at their worst. Uh, and the one thing, though, that does not get better over time, the one thing that gets progressively worse and that we really have to act on and do maintenance therapy for are the vulvovaginal changes of menopause, the so-called genitourinary syndrome of menopause. The vulva, the vagina, the urethra, the bladder, all those genital and genital adjacent tissues become estrogen deficient and the tissue integrity really suffers. Thin, dry, fragile, painful, all the things I mentioned before. That is going to get worse and worse and worse over time if it is not addressed. So while a lot of the symptoms will get better over longer periods of time, the GSM symptoms, the genital symptoms, will get progressively worse. Good news is we
Understood.
can treat them. We can prevent the eventual malfunction of that system if we are aggressive and early and committed and ongoing with treating the genitals. Very important.
Understood. Someone had asked in regards to a recording of today's session. I did put this back in the chat, but just to say this out loud too, we send out a recording of today's session. We are recording. It's for educational purposes, of course, but also we send that out to you. If you are attending, we'll send this out to you so that you could go back and listen. I find it important just for you to be able to have somewhere to go back and listen to how something was phrased by Dr. Lisa to help
Show your
maybe,
friends, invite
yeah,
people
share with your,
over, make some
absolutely.
popcorn, and
Yeah.
tell your girlfriends. I think the girlfriend network is so important. We have to support each other as women. It's a sisterhood. And so if you're hearing things today that are helpful to you and you think would help somebody else as well, pass it on. I think it's so important.
Yeah, and I'll add too. I like asking this question, especially with our doctors in our one-on-one sessions. From my point of view, as someone who is not going to experience menopause, my question is always centered around how can I be a partner? I am married, and eventually my wife will go through menopause. So my question more so for you, Dr. Lisa, and for those that are listening, if you have a spouse or a partner, or you have members of your family, how can we direct conversation around how to talk to our partners, our spouses? How can I myself be a better partner by understanding this? How would you help frame that?
Well, Tyler, you're going to be the best partner because you're going to know all of this.
Right.
But a lot of partners, spouses, others, they don't know all of this. But women don't know all of this. So I think that the key is education and open communication, sharing. Hey, honey, guess what I learned today? This is what my body might be going through, and this is what I might consider to support it, and I need your support as well. I just think that opening up those lines of communication and bringing our partners in, this is no big secret. I mean, we suffer with menopause a lot, and therefore our loved ones suffer with us or because of us, whatever it is. They have to be part of the solution. They have to support us in our seeking help, education, resources, etc. So don't keep it a secret. Bring people in, whether it's your spouse, your children. They may be young adults by now. Certainly, they can very well understand these things. Others in your world, your coworkers. And we have so much at Genève of an emphasis on menopause in the workplace. Because here's the thing, ladies, we're at the peak of our careers when menopause comes around. We are fulfilling a lot of different roles. We are important at work. We are taking care of aging parents. We're shepherding our teenagers or young adult children. We have a lot of roles, and especially in the workplace, menopause can affect us a lot. Absenteeism can be up, performance can be up. A lot of different things in the workplace come to mind. And so educate others in your world, whether they're in your family or in your workplace or elsewhere. Share it and, let them support you as they can.
Yeah, I love that. I think the context is important too. Being able to open those channels of communications, being someone that's seen as a partner and a liaison.
Yeah, this is not our
I
mother's
think that's really
menopause. We're
empowering.
going to talk about this. A lot of patients say, I ask, well, how old was your mother? Oh, we never talked about those things. And that's a little bit generational. I think now we're much more inclined to be more open in our communication. Certainly, I mean, my young adult daughter knows a lot. Of course, her mother's a menopause specialist, but still, I mean, we can educate others, and that just benefits not only us, but the younger generation coming on through. We want to reach down to them and bring them along so that when they get to this stage, perhaps it can be easier for them.
Yeah, absolutely. That's wonderful. Thank you. Someone had asked, and I have data behind how to answer this particular question, but I wanted to hear it from your point of view, Dr. Lisa. But someone had said, how soon have clients experienced some relief or improvements, a general window? I
Oh,
know when
that's
I'm
great.
giving a presentation to, prospective employers or just even companies that are under our network, we have a general frame of 87% of our patients, state after their first appointment with us having some type of symptom improvement, 87%. But I would love to hear from you, Dr. Lisa, like put that number into words, if you will. If you could give some
Okay.
descriptives around, like, what does that mean exactly?
Well, it depends on what therapy we're talking about. Because some therapy, for hormone replacement, for example, will have a different onset of action and expectation than compared to an alternative. Hormone therapy, I tell my patients, I hate to overpromise, but within 2 days to 2 weeks, something good is happening. Now, I always emphasize that may not be the pinnacle of success, that might come later, but there's not a lot of delayed gratification on using hormone therapy. Now, some of the alternatives might take longer to really bring full relief. For example, for some women who can't take hormone therapy or don't care to, one of our alternatives is the antidepressant category, the SSRIs, things like Effexor, Zoloft, Paxil, etc. Those can be an alternative. Now, those medications are going to take longer for a woman to notice symptom relief. Not forever, but we just have to specify which therapeutic we're talking about in terms of what to expect for symptom relief timeframe.
Understood. Someone had just asked a question that was, I feel like, a continuation of something you had talked about just a few minutes ago in regards to hysterectomy and
Mhm.
ovaries. But someone had said, are symptoms different if menopause occurs naturally versus having a hysterectomy with ovaries removed?
Yes. If you have abrupt menopause, in other words, today your ovaries are with you, and tonight, because you had a hysterectomy today, they are gone. The symptoms are more intense than if they came on gradually through a sort of natural occurrence of menopause. So patients who, and it depends on age too. So if you have a hysterectomy and you're already 52 and you've already been experiencing some of the symptoms, yeah, they might be acutely and abruptly more intense. But man, if you're 42 and you have the hysterectomy and the ovaries removed, it's really intense because of the younger age. So, in a word, yes, things are more acute and more intense with surgical menopause than with natural menopause, and age is a factor.
Understood. Um, Someone had asked, is there any medication that can help if you can't take estrogen due to high risk of breast cancer?
Yeah, absolutely. One, let me just mention this thing about breast cancer first. Depends on what risk profile we're talking about. For example, just having a family history of breast cancer may not disqualify you from being a fine candidate for hormone therapy. So we'd have to individualize on what we're talking about in terms of high risk. But let's say we have a patient who herself has had breast cancer. She's a survivor of breast cancer. We have a whole toolbox full of alternatives that we can use. And a lot of our patients come in and they're seeking alternatives because HRT is not an option for them. And we have several things. There's one medication that is specifically for hot flashes and night sweats, and it works about as well as estrogen does. It's called Veoza. We have other medications that we can use for various symptoms. It depends on the symptoms in terms of which tool do we take out of our toolbox for this particular patient. I mentioned the SSRI category of antidepressants. Those can be one of our tools. There's another medication called gabapentin, originally a neurologic medication, sometimes used for pain management. We use gabapentin because it can have a positive effect on those hot flashes and night sweats. So yeah, we have a whole toolbox in front of us in terms of alternatives, which is very encouraging.
Yeah. Yeah, that's very helpful information. Continuing conversation, I think, you know, when you, first set up your experience with us here at Gen these are the types of conversations that you be able to have directly with your OBGYN, and it's even going in more detail. So for those of you, again, another plug, if you have yet to create your Gen account, I would love the opportunity for even just Dr. Lisa to be able to speak with you, but any of our other doctors and OBGYNs to be able to give you more insight, more directive, more specific conversation around you and your journey that's unique to you. Continuing here, someone had asked, do patients come in that don't require medical interventions?
Absolutely. A lot of patients come in just seeking good information, solid advice, reliable um, resources. Not every woman who comes in is interested in medical therapy. She just wants to get some really well curated advice and information about menopause, because it can be a little bit hard to sort through. If you Google menopause, oh my gosh, it's like drinking out of a fire hose. And how do you know what's reliable and what's not? Well, one way is to go to the Genève website, because our information there is solid. But yeah, plenty of women come in, and maybe they don't need medication. They just want to talk about their symptoms and perhaps non-medical lifestyle modifications that can help them thrive through the transition.
That's wonderful. Someone had said, is there any connection between perimenopause and high cholesterol?
Well, lipids do start to change with the drop in estrogen, absolutely. And some women who've had normal lipids their whole life all of a sudden start to creep up as their estrogen comes down. So lipids are something that we keep an eye on. At Genève, we're not necessarily the primary ordering physician for your lipid panel, your cholesterol panel, but it's something that should be done as part of every screening. Maybe not every year if it's normal. I think the recommendations are every 5 years if it's normal. But if not, or if it's kind of bumping up against the abnormal values, checking that more frequently would be indicated. But yes, the menopause transition can absolutely have an effect on the lipids, and
Thank you.
therefore on cardiovascular health, right? One thing leads to another. So long term, we think about cardiovascular health, because what is the number one killer of women? Cardiovascular disease. Not breast cancer, it's way down on the list. It's cardiovascular disease. So we have to think about all these things in terms of that long-term picture.
Yeah, I'm glad you drew that parallel. I've heard that described by so Genev's chief medical officer is Dr. Rebecca Dunsmore Sue. She has also given this menopause 101 session before, and she has talked about a little in regards to that cardiovascular piece. So thank you for bringing that up. I think that's a good point. Is there any other, in regards to cardiovascular specifically, what types of conversations are you having with your patients to be more cognizant of that particular risk?
Well, all the things that people mostly know about nutrition, obviously, don't smoke, exercise, all those things. That's where our lifestyle division can really offer a whole lot of support in terms of nutrition, movement, lifestyle modifications, forming good habits, getting rid of old habits that are not so good. Yeah, it's not just this or that, it's all of these things. It's never too late either. I mean, I don't want people to have the impression that if you haven't done all these things by a certain stage, then all is lost. Absolutely not. It's never too late, and we're here to support women at whatever point they're at.
That's wonderful. Thank you. Someone had said if you have endometriosis or still have mild endo, is that an indicator or have an impact? I would assume probably on menopause journey, maybe specific to them.
Right. Not necessarily, but I will say that one thing about endo is that it frequently is still active all the way up into menopause. And one good thing about menopause is that endometriosis usually ceases to be a problem, because the ovarian hormones fertilize endometriosis. Once you don't have the estrogen and progesterone anymore, the endometriosis will generally shrivel up and become a non-issue. But getting to that point, say in your 40s, a lot of times endo is a real problem, because you have all these fluctuating levels of hormones. Sometimes they're high, sometimes not. And so it can be an ongoing problem up until the point at which those hormones are very, very low. Um, To address that, a lot of times in perimenopause, say a woman's still menstruating, still having endo issues, we're going to use a low dose birth control pill because that's a primary treatment for endometriosis to begin with. And it serves as hormonal balancing in a woman who's in the transition but still menstruating. So I just saw a patient on Monday who had that exact same scenario. Mid to late 40s, still has endo issues. Perimenopause is coming in now, and we have a solution for that, and it's called oral contraceptives. Suppresses the endometriosis, treats the menopause symptoms, and for eligible patients, may be able to take it until the age of 55. And that's the point at which we pivot over to menopause products.
In regards to menopause products, someone had actually asked kind of around a good daily vitamin for postmenopausal stages, or what should postmenopausal women take? I know, giving specific recommendations kind of in a group setting could be difficult, but if you have any type of recommendations or things to be cognizant of.
Yeah, remember what I said about MDs not having a lot of education in the area of nutrition? And honestly, data says that vitamin supplementation is usually not necessary. If you have a really good, healthy diet, you're getting those nutrients from your food. Multivitamins in general are this multi-billion-dollar business, and there may be some specific supplements that are indicated. For example, vitamin D. But as for a multivitamin, I'm not a huge fan. It's not that I've never taken a multi, but if you look at the scientific data, if you're eating a reasonably healthy diet, you should be getting all those nutrients from your food. Your body uses them better that way than by taking anything in pill form. So I don't want to be too down on multivitamins. Perhaps our chief nutritionist should come on to address that a little bit more. But I do want to put in a plug for vitamin D because it's necessary for our bone health. And even in sunny climates, like where I live, it's too sunny, too much. But even in sunny climates, a lot of people don't have enough vitamin D to support good bone health. So that's one supplemental exception that I'll say a lot of people still need.
Vitamin D. That's a good shout. I will say, to give another plug for another webinar that we have done. If any of you are familiar or have utilized YouTube in the past, Genev does have a presence on YouTube. All of the recordings that we put together for our webinars are on our Genev YouTube page. And a few months ago, we did have our chief dietitian actually present on lifestyle support in menopause. And a lot of the questions were very specific to kind of her job and her role here at Genev. And I would really highly encourage you, if you are having questions around, what types of vitamins I should take, or, how should I include this particular food group into my diet? Those types of questions were the types of questions that we were talked through. And I believe it was in March, and I think we did another one just last month, actually, just about lifestyle support. So I would highly suggest you go look on our YouTube page. We'll send a link out for today's webinar. I'll include our YouTube page in that email too, so that it's just easy for you all to go and click.
And that's a good point about that expertise. The other thing is, say you need a supplement of some sort because you actually have a deficiency or you're at risk for having a deficiency. Product choice really matters too. I know I've reached out to Stacy, our lead dietitian, to say, what manufacturer would be a reliable one? Because honestly, there's so many products, and what's on the label might not be what's in the bottle. So careful about that too. You can spend a lot of money on supplements that may or may not be helpful.
Very true. I had a question come in just in regards to like migraines. Someone had said, is it common to see the incidence of migraines increasing during menopause?
That is very great question. Just this past week, I've seen a couple patients whose migraines were one of their presenting complaints. It can go either way. Sometimes vascular headaches get better, sometimes vascular headaches get worse. We usually end up doing a real detailed history about how those migraines behave around cycling if it's still ongoing. A lot of women have menstrual migraines. They come at the end of the cycle, they're super predictable, etc. Um, And other women have more random headaches, but it can absolutely go either way. I've seen patients go, "Oh, one good thing about menopause, my migraines have really quiescent." And other women are like, "Oh my gosh, this is terrible. They've really ramped up." So we just take that individual history and sort of see how to address it. We're not headache specialists, but certainly hormones can play a role, especially in those vascular headaches. So we try to recommend therapy based on the individual symptoms and how that patient's headaches are responding. I just saw a patient the other day whose neurologist referred her to us because her neurologist wisely knew that this woman's hormonal pattern or lack thereof was contributing to her headache behavior. And so, again, collaboration. I was able to send my notes to that referring physician. And so the patient benefits, we're all on her team.
Yeah, that's great. And with that said, I have heard it described again by Dr. Rebecca, who, if you have previously attended a webinar of ours, she's kind of put it this way: is a lot of collaborative care does take place, and it's the little c. When you start getting into the weeds of insurance billing, there is such a thing as called collaborative care. That's capital C, and all the lingo associated. That's not what I'm mentioning here, but the collaborative care where an OBGYN is being able to either refer out or gather information with the patient's journey, and that can be pretty empowering too. If you could talk about that a little bit, Dr. Lisa, maybe like a scenario or two, maybe relative to a patient's experience.
Well, I'll give you the example of that patient I just mentioned. She was a woman who's in the throes of perimenopause, um, seeing a headache specialist, a neurologist with a niche practice because her headaches have gotten so bad, absolutely coincident with her perimenopause. About 3 years ago, when she started having hot flashes, that also coincided with an uptick in her headache frequency. And she's on several things for those headaches. But her neurologist, seeing that there was some kind of hormonal interplay going on, sent her to us. We were able to help manage the hormonal situation. It's not that she won't need the headache management anymore. Yeah, she probably will. But hopefully things will be a whole lot better. And because we run our medical practice on a very standard electronic health record, I'm able to send visit notes to whoever referred the patient, whether it's a specialist, a primary care, a fellow OBGYN. And so that's really great. And we try, if somebody has been referred in by an outside physician, to share notes with that physician from the doctor's perspective. Our patients can also print out a copy of their entire visit and take it to whomever might be interested. I always encourage people to do that. It's like print it out, take it to your primary care. We can do a little education of them at the same time.
Yeah. um, that's really important to call out, and I think those types of conversations can be very important. We're kind of winding down here at the end of the hour, and we'll probably have room for maybe one to two more questions. While we're doing that, what I wanted to do is just plug one more poll, and it's usually a typical poll that we add here at the end of our webinars, but we really just wanted to see if you are feeling more knowledgeable about menopause after attending today's session. If you could, we would love for you to just take some quick time to add your answer for us. And from there, I think we'll pivot back after you're able to input your answers into our poll. There is really just maybe focus on maybe two more questions. Trying to find some maybe relative to some of the current topics that we had talked through. Someone had asked, and I'm not sure, Dr. Lees, if you'd be able to give any specific info on this, but I'll ask it anyways. How long after surgical menopause should someone get a bone density scan?
It really depends on at what age that surgical menopause occurred. The U.S. Preventive Task Force doesn't recommend a bone density until age 65. Um, but a lot of women are really at risk for bone loss well before that, and it depends on other risk factors: thyroid, body weight, smoking status. There's a lot of things that go into at what point do we order a bone density test. So it's more than just age at menopause or age at surgical menopause. A lot of other factors have to do with that too. We don't want to get it too early. Um, there's rarely a place for a bone density in somebody who's in her early 40s unless she has specific other risk factors. But the most rapid time of bone loss is right around the transition into menopause. And so we don't want to ignore that. But I tend to look at a lot of other factors, the ones that I mentioned, in terms of, does somebody need a bone density earlier than, say, you might otherwise get one?
That makes sense. Um, I will say, looks like we've got one more question here that I'll ask you, and then we'll end today's webinar session. And I feel like this is probably a good question to end on because I think it's kind of a more of a wide ranging, but just a kind of a good need to know. But does HRT or oral contraceptives cause inflammation in the body during perimenopause?
No, quite the opposite. So estrogen is a mild anti-inflammatory in and of itself. And that kind of explains why so many menopause patients complain of joint pain and just overall body pain. They've lost the anti-inflammatory effect of estrogen. So no, I don't think that those hormonal therapies are pro-inflammatory. I think quite the opposite.
Understood. Well, I really appreciate your time today, Dr. Lisa, and all of you that took
It's
some
great.
time to put your questions in the chat. I hope today's session was informative. It felt maybe specific to you in some particular way. And again, if you would like to continue the conversation, we'd love to have that with you by just creating a Genev account and then getting synced up with one of our OBGYNs or our doctors or even our registered dietitians and those services. We're all about collaborative care here, and it's just about working together to see where you are at on your journey. And with that said, have a good rest of your Wednesday and a good rest of your week. And again, thank you for attending.
Thanks, everybody. Enjoyed
Thank you
it.
so much. Take care.
Bye.